Our final speaker for the session is Dr. Rodrigo Reis. He's a professor and director of the Office of Public Health and Assistant Vice Provost at the Washington University in St. Louis. His research focuses on physical activity and public health, with particular interest in community interventions for promoting physical activity, the built environment in public health, active transportation in health, and physical activity surveillance. He's worked extensively to build physical activity research and practice capacity in Latin America. He's a founding member as former president of the Brazilian Society for Physical Activity and Health and a founder member and current board member for the Latin American Congress of Physical Activity and Health Research. Please help me welcome.
Thank you. Thank you. Thank you. 1, 2. Very hard to follow, Valerie and Adolfo. Amazing speakers, very inspiring. And I'm glad that you set the stage for some of the things I will share with you. So being born and raised and trained in Brazil and transplanted to St. Louis nearly 7, 8 years ago, I have a perspective of somebody who has immigrated later in life. And I bring those angles in this presentation as well. So part of what I'm sharing with you is heavily influenced by my experience as a Brazilian researcher and citizen, but also somebody who embraced St. Louis as a home as well. It's very common in U.S. to lump everybody that lives below the Mexican border as Latin Americans. We are not the same. We are very diverse. It's a very rich region. We have hundreds and hundreds of languages of native-speaking people that have been largely neglected, particularly in public health and practices. And we don't speak Spanish only. We speak French, English, Spanish, Portuguese, and Creole. And it's a very diverse and rich region. And it's important to say that because we are living in times where the crisis at the border is informing the conversation in public health with angles that do not represent Latin America the way it should be represented. The second aspect is, it's a very, very unequal region in all aspects you can imagine. Racial, spatial, economic, and social inequalities are very pronounced across the region, and particularly in my home country in Brazil. But we live in conditions that are quite similar to the US, that is becoming rapidly very unequal. We live in places in the US where inequality is actually higher in places in Latin America. So I think this bidirectional conversation for dissemination implementation is quite important, because things we learn here in the United States can inform Latin America, but practices and research that are based and done by Latin Americans in Latin America for Latin America can inform the Latin American populations that live in the US as well. So I think I want to highlight those two angles before I say anything. And finally, we also live in a very, I would say, vibrant region. I'm trying to use a positive word. From Milei to Maduro, from Bolsonaro to Boric, it's very ideologically diverse, but it has been charged for decades. But the last 10 years, we are experiencing large changes in politics and economy. And it's not a coincidence that public health and health services are being threatened by those changes across the board. In Brazil is no different. And COVID actually made those changes even more pronounced and affecting more people and so. It's not a coincidence when living the same thing experience in the United States now, where the division, lack of a better word, let's call it ideological, although I think it's very poorly framed as an ideology, has been also divisive. How Latin America sees health is also different in a way. We are largely community-based in a society that sees community as a collective construction. And the ontology of public health in Latin America informs the epistemology of public health. We even call public health sometimes collective health. So it's less individual responsibility-based action than more community responsibility and driven sort of action. So that's not a minor distinction, because interventions based in our experiences in Latin America that are implemented in the US are not completely transferable. Same with what we are seeing in the United States, where this ontology and epistemology inform both how people see health, but also how we conduct health research, cannot be translated to Latin America automatically. So I wanted to say that before I say anything. So I want to share with you some of a collection of the results of findings we have done in the last maybe 10 years. Many colleagues contributed to this, including my great friend and professor here now, Andrea Ramirez, who's sitting there, Ross Brownson, who have been working with for years now, and others as well. So the best way, I will frame my first part in Brazil. I'll try to be minimum with 10 minutes. I think I will maybe go 2 minutes over. And let's frame Brazil in this context. And I'll talk about dissemination first. So the best way to see somebody position in the world is comparing to other people sometimes. It could be fair or unfair, but you can tell where this people stands. And we'll compare how researchers in Brazil disseminate their results and how they rank their efforts in dissemination. So as you can see, the efforts of dissemination in Brazil are not as highly ranked as in other countries, and particularly compared to the US. So how researchers are disseminating results, Adolfo really framed that really well, is more passive, in a passive way. So it's very hard to talk about implementation if you don't consider that dissemination is not really going beyond academic journals, as you can see in this slide as well. And particularly for Brazilian researchers, other forms of dissemination are not really present in their practice. A good distinction is important to make here. In Brazilian academic system, you cannot be economically or monetarily incentivized to publish. You cannot build your salary up on research. You cannot bring any funding into your salary by law. So the incentives for promotion are not monetary incentives, but are more promotion incentives for going up in the ladder for promotion and ranking and status. Obviously, you have some informal or indirect form incentives because you can attend conferences and so, but you cannot build a salary based on research. That's an important distinction when we think about dissemination efforts. It's not only providing monetary incentives, which we could do in US, for instance, if we frame calls for grants, for instance. But in Brazil, in other societies in Latin America, probably not the solution. We have to provide more structures and training. And we have seen that in our findings for this research, where the use of frameworks is very little in Brazil. So people are not trained to use dissemination frameworks, not even implementation frameworks. So training capacity is really lacking among researchers. And now I'm talking about the highest ranked researchers in the Brazilian academic system. And we'll talk about the predictors of better efforts of dissemination. Again, training and structures. So we don't have structures in those academic environments to provide good communication strategies or even communication resources. So I would say if we want to improve dissemination, particularly in Brazil, we have to provide better infrastructure for that. You cannot expect the researchers will be doing that without any means of being incentivized or being trained or having access to resources. So that's lesson number one, I would say. We also compared how, this is 2 or 3 years, I think we published this 3 years ago in a misimplementation project we did across 4 countries. But one question that we asked was about how knowledgeable practitioners across 4 countries are about their access to evidence on promoting chronic disease prevention strategies and interventions. So basically, how knowledgeable you are about NCDs and efforts. And again, you see the rankings there, Australia, Brazil, and China. But the knowledge compared to US among practitioners in Brazil, it's lower. So training what is the best evidence among practitioners is quite important. So here you see the 2 sides of dissemination. Who is releasing the information, producing and releasing the information, and who has been having access to that. So if you don't train how people read and have access to that information, it doesn't matter how much effort to put in the dissemination. So we have to tackle both sides. So we did some contextual research. This is another paper. It was more qualitative, but again, the results are quite revealing. And the best information we have about increasing dissemination uptake, and here again, we're talking about practitioners working in public health, is really increasing resources and training. So the context matters, but providing training capacity to use the resource, using the information is good. So I think I'm repeating what Adolfo has said, maybe. Nothing new, you just said that. So we went a little deeper and we talked to states, the local department, local health department directors in a state in Brazil, 300 directors, 300 cities in one of the states in southern Brazil. And we ranked the cities about the good and bad experiences about delivering NCDs related projects. So they self-rank themselves with the highest or lowest efforts and successes in doing that. And you see a striking difference in the local departments. They are not doing well. The local departments, they are not delivering those strategies well. And this is self-ranking again. They don't have capacity to do the basic EPI and public health efforts. Quantifying the issue is one of the basic things we do. This is EPI 101 probably. And so and these people are working with populations already. So it's not a matter of wanting to do the work, it's having the knowledge and the ability of doing that with the best evidence. So again, training both sides, it's important. I'm trying to rush. So we compared what is important and what is feasible. Now bringing back to the sphere I work most is physical activity in public health in different countries, particularly in Brazil and also in the US. And you see the importance of delivering policies is recognized, but the feasibility of implementing policies is very low. So it's not a matter of recognizing the importance of policies, but how well we can implement them at a local level. There might be shifting the discussion to more effective. This is a paper published by my friend here, Andrea Ramirez, and particularly in physical activity, you see the number of publications across 50 years of history in public health and physical activity. If you see in the bottom side, on the right side of this slide, we don't know much about what works. So in the absence of a lot of evidence about interventions that have been evaluated and published, what should we be doing? So that's a question that should be asking. Should we implement what we have? The second problem we have so little, right? The second problem we have is this. You see on the upper side, you see the size of the country is reflecting the number of the people living in the country. On the bottom side, you see the number of publications by country on physical activity and health. So no wonder where we see a gap as well. A lot of publications coming from the global north, very little from the global south. So how can we implement contextually relevant interventions when you don't know if they work in that context? They have been not produced in that context. So we have to think about how we can decolonize the science behind implementation in public health and build local capacity. I'm a good example of brain drain in Brazil, and several of you are as well. So we build capacity and we don't leave capacity. So how can we keep capacity to produce good science and to move things faster? So we know the solutions that work across the globe. This is a framework for WHO. I'm not going to go deep into that. But we did another study a few years ago asking, so what works at scale? So very little have been published. But a lot of things have been implemented that have not been evaluated. So when you ask about what things can be implemented at scale, what happens when we don't have the information that is needed? When we have is very little and not contextually relevant, well, people are moving things faster, but they don't know if they work. So the question is not scalability. We know things are scalable. The question is, are the things that are scalable working effectively or not? So maybe you should reverse the conversation and think about what makes the things that have been scaled up more effective and not trying to scale up things that we find effective first so we can move things a little faster. So we ask that question. Sustainability is the major aspect to improve scalability interventions, again, on physical activity and public health. I'm going to the end of my presentation before people kick me out of the stage. Only 2 slides. So we found good examples. You see here 3 examples. On the left side, you see an example of a study that has been well documented, evaluated, evidence-based, and have been scaled up. On the right side, you see example of programs that have been scaled up across the African continent, and they have never been evaluated to promote sports and physical activity. So we should be examining things that have been taken to scale. We understand how could the context have been embraced and how those things became so popular and adopted across different countries and cities and states. And maybe that's the key for the success. And so that's the final call. We developed a model showing that what we found in that paper is that actually the pull and push factors should be considered. Not only the best evidence, but things that have been adopted without the best available evidence, and combine those two words to improve our implementation efforts. And that's my spiel. Thank you so much.